Good morning. Thank you for the opportunity for letting me speak with you today. I will be presenting preliminary data from a randomized controlled trial of a pediatric tele-emergency program. So first of all, I have no conflicts of interest to disclose. So each year, approximately 30 million children, 18 years and younger, visit the emergency department in the United States. However, only about 6% of all EDs are fully equipped to care for these pediatric emergencies. Compounded with this, about 26% of all pediatric ED visits nationally are to hospitals in rural areas who have especially limited access to pediatric specialists and low patient volumes, making it difficult for these hospitals to maintain high-quality pediatric services. This lack in resources among rural and underserved hospitals has been shown to lead to deficiencies in the delivery of care for children, resulting in delayed diagnoses and inappropriate therapies. Research has shown that the immediate availability of pediatric specialists improves the overall quality of care that critically sick children receive. Therefore, one solution to addressing the shortcomings in access to care for children presenting to rural and underserved emergency departments is through telemedicine. Telemedicine in the ED, otherwise known as tele-emergency, is the use of live, interactive video that brings pediatric specialists virtually to the bedside of patients in remote hospitals to assist in the care of children 24/7. Within the tele-emergency network at UC Davis, outside hospitals will first call our pediatric or neonatal critical care physicians to request a consultation. Our physicians will then call into their telemedicine unit, which is located in the outside hospital's emergency department, to see the child and to discuss the management of care with the remote ED physician. So previous studies from our UC Davis team have found that tele-emergency consultations for sick children have resulted in higher quality of care and higher parent satisfaction when compared to telephone consultations, as illustrated in the top two graphs. Telemedicine has also resulted in higher provider satisfaction, more appropriate diagnostic decisions, lower medication error rates, lower patient transfers, and is more cost-effective compared to the traditional use of telephone consultations. These studies, however, have only been conducted among a small cohort of just 6 to 10 hospitals. Therefore, many questions still remain about the true impact that telemedicine has on clinical and financial outcomes, and therefore a large, rigorously designed study is needed. To fill in these gaps in knowledge, the UC Davis Children's Hospital is conducting a multi-center, crossover, cluster randomized controlled trial to determine the impact of a pediatric tele-emergency network on quality of care, appropriateness of transfers, patient safety, and cost effectiveness compared to telephone consultations from a healthcare system perspective. For this study, we included children less than or equal to 14 years old presenting to emergency departments who received either a telephone or telemedicine consultation from a UC Davis pediatric or neonatal critical care physician. We have randomized at the hospital level rather than the patient level for feasibility and to avoid potential contamination, and data will be collected through retrospective chart review. Hospitals have been recruited to begin the study at different time periods and will remain on the study for 2 years. Therefore, with this rolling admission, the complete study period is from November 2015 through March 2018. We've recruited hospitals from our existing UC Davis Pediatric Tele-Emergency Network, which the map on the left represents. UC Davis Medical Center is represented by the red star, and the remaining blue pinpoints are the hospitals within the existing network. These hospitals include a mix of rural and underserved mostly, and a few urban-based hospitals throughout Northern California. 16 hospitals from this network have been recruited and are assigned to 4 6-month blocks throughout a 2-year period for data collection. During 3 of the 6-month blocks, sites are randomly assigned to receive encouragement to use telemedicine, and during 1 of the 6-month blocks, sites are randomly assigned to receive encouragement to use telephone. Both the UC Davis physicians receiving the call for consultations and the remote hospital ED physicians are aware of the randomized assignment. Although encouragement for a particular intervention is present, the decision is ultimately up to the UC Davis physician and the remote ED physician who are caring for the child. The objective of this current presentation is to provide preliminary results of this pediatric tele-emergency study from November 2015 through the present of March 2017 on protocol adherence, patient age, and transfer rates, comparing those who received a telemedicine consultation and those who received a telephone consultation. We used Pearson's chi-square test to compare categorical variables and students' t-test to compare continuous variables. To date, 444 children met the enrollment criteria and were randomized to receive either a telephone or a telemedicine consultation. Of the 99 children presenting to sites that were assigned to use telephone, about 82% of the time telephone was used, and about 17% of the time telemedicine was used. Of the 345 children presenting to sites that were assigned to use telemedicine, only about 34% of the time telemedicine was in fact used, while 66% of the time telephone was used. So instead of seeing 70% of the consultations being conducted by telemedicine, we're actually seeing the opposite. It's important to note, however, that some calls that are assigned to telephone are actually being conducted over telemedicine. So we're seeing this interesting bidirectional elective deviation from the protocol assignment. The percent of telephone and telemedicine consultations conducted in each age group is illustrated, with telephone represented in blue and telemedicine represented in gold. So overall, the percent of telephone and telemedicine consultations are about the same across the age categories, with the percentage of telephone consultations typically being slightly higher. However, for children's ages 1 through 4, we see an opposite trend, where telemedicine is used significantly more than telephone compared to children across the other age groups. Lastly, of those who received a telephone consultation, about 89% were transferred to receive a higher level of care. And of those who received a telemedicine consultation, about 71% were transferred to receive a higher level of care. Therefore, those who received a telemedicine consultation are significantly less likely to be transferred than those who received a telephone consultation. So these preliminary findings provide evidence that among both intervention groups, there is an elective deviation from the protocol assignment, suggesting that telemedicine is strongly preferred in some cases while not in others. Second, younger children may be more likely to receive a telemedicine rather than a telephone consultation compared to other age categories. And lastly, telemedicine consultations may result in fewer patient transfers. This finding may be due to the guidance that is provided through telemedicine that may change diagnostic decisions, such as changing the medications needed or confirming a non-critical event that may allow the patient to be treated at the referring hospital. So moving into the last year of the study, we now plan to collect additional data from physicians on why they decided to use a certain consultation type despite an encouragement in the opposite direction, to really understand the important clinical decisions or important clinical reasons that are driving these decisions. So we will also continue to collect data in order to determine the impact of a tele-emergency consultations for sick children on the quality of care received, appropriateness of transfers, patient safety, and cost effectiveness. And we look forward to updating you on our final results. So in conclusion, these preliminary data provide encouraging results, specifically that telemedicine consultations provided to critically sick children in emergency departments may result in recommendations that allow children to stay in their local communities more often than when consultations are provided using the telephone. Avoiding unnecessary transfers and keeping kids in their community when possible relieves a burden off of the patient, the family, and the healthcare system, allowing for more time and resources to care for those children who need it most. So I'd just like to thank and acknowledge HRSA, who has funded this project, and the rest of the project team listed here. Thank you.